So, hello everyone. I hope you're all having a great evening, and thank you again all for joining us today. My name is Nasreen Shahimi, and I'm the events chair of the Pharmacy Alumni Association, and I will be the host and co-moderator for tonight. And so, I'd like to first start off that acknowledging that the University of Alberta and RXA are located on Treaty 6 territory and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and the First Peoples of Canada, whose presence continues to enrich our vibrant community. So the mission of the Pharmacy Alumni Association, or PAA for short, is to engage, connect, and celebrate the University of Alberta pharmacy alumni. So we're very excited to be co-hosting this event with the Alberta Pharmacists Association and the Faculty of Pharmacy and the Pharmaceutical Sciences. So thank you again all for taking the time to be here today. I think this is a really important topic, and we're so excited to have such an amazing panel join us. So although it's the end of March, I would still like to take the opportunity to wish you all a happy Pharmacist Appreciation Month. And so through the unprecedented challenges of the past year, the pharmacy community has stepped up and continues to step up like never before to serve our patients and our communities. I've never been more proud to be a pharmacist, and through events like these, we hope to always provide pharmacists and students with varying perspectives from pharmacy leaders on important topics such as mental health that affect our profession. And so this is a topic and presentation that is very important. So thank you again all. Thank you again to all the speakers for joining us today. And yeah, I'm really looking forward to this discussion. So I'd like to now introduce Alan Doughty. Alan is the Development and Alumni Engagement Officer for the Faculty of Pharmacy and Pharmaceutical Sciences.
Thanks so much, Nasreen. It's such an honor to be here this evening representing the faculty in partnership with RXA and the PAA. After being with the faculty for over a year now, I have gained such a deep appreciation for the incredible work that pharmacists do to support the community. So thank you to our alumni, donors, students, colleagues, and friends for joining us this evening. I'm looking forward to an engaging discussion.
Thank you, Ellen. I'd like to now introduce Ali Damani. Ali is the Director of Professional Affairs for the Alberta Pharmacists Association.
Thanks, Nasreen. As Nasreen mentioned, my name is Ali and I work for RXA. Welcome. We're excited to be co-hosting this event with the PAA and the Faculty of Pharmacy. As you may or may not know, RXA works to promote the value of pharmacists and supporting and advancing the health of Albertans. As a nonprofit, member-based organization, our vision is to be the voice of a unified, innovative, and inspired profession. We do this through advocacy as a recognized voice for pharmacists in Alberta, through continuing education, and through support by empowering pharmacists with arguably the widest scope of practice in the world and the resources to put it into practice. What really excites me about these events and the panelists is the focus on the patient and the discussions that provide practical ways in which we can support them. It challenges us to open our minds on how to enrich our practices, and by engaging with patients, we showcase the value of pharmacists. So thank you all for attending tonight.
Thank you, Ali. Our panel discussion today is approximately an hour and 15 minutes in length. So we have 4 amazing speakers joining us this evening, and the format of this discussion will begin with the speakers describing a patient case or clinical scenario they have come across in their practice, what actions they took to achieve a resolution, and any take-home messages that they have to share. So we hope to achieve our objectives, which include discussing non-traditional methods of identifying mental health concerns in patients, how to utilize communication tools to effectively initiate a discussion and conversation about mental health, referring patients to appropriate mental health resources, recognizing the signs of a mental health crisis and assessing for suicidality, and knowing how to check in with our colleagues that might be experiencing mental health issues such as burnout. So just a little bit about how the format will go. So after all the speakers have had the opportunity to discuss, we'll then open it up for questions and a discussion. So we've received tons of questions from the audience before this event, and so we'll be discussing those questions in the end if time permits. So with that being said, I'd like to introduce our amazing panel moderator, Dr. Ravina Singera. So Ravina Singera is the Assistant Dean of Student Services and a Clinical Associate Professor with the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta. She received her undergraduate pharmacy degree at the University of Alberta and her PharmD through the University of Colorado, Denver. She's practiced in community pharmacy for over 10 years and currently has a practice focused in dermatology at Rejuvenation Dermatology Clinics in Edmonton. Welcome, Ravina.
Thank you so much, Nasreen. I appreciate the invitation to co-moderate this evening's virtual event with you. Welcome attendees and panelists. Hopefully you have something cozy, maybe in your hands, like a warm cup of tea, maybe you're finishing dinner, or maybe you treated yourself to a nice dessert for today's event. I hope you are comfortable, and I look forward to today's evening and enjoying it with you. Now, I was speaking to Ali earlier this week and learning more about the event. And we started talking about that sometimes as pharmacists and as clinicians, we have this inertia where we identify a patient who is in distress or is in need of further support. But this inertia and this fixation on us to be perfect, to recall clinical guidelines, to recall that validated tool that we should be using kind of hinders us from reaching out to our patients. Well, today's discussion is hopefully going to help give us some simplistic measures we can incorporate in our practice to really start forming those bridges. So I'd like to introduce our panelists and speakers tonight. We have Ezi Salukangas, who is a clinical pharmacist with a passion for improving health outcomes in structurally vulnerable populations using evidence-based practice, empathy, and relationship-based care. A University of Alberta 2016 alumna, Essie went on to co-fund the Adherence and Community Engagement ACE team, a pharmacist-led interdisciplinary outreach team, and is now the first clinical pharmacist on the Addiction Recovery and Community Health ARCH team, an addiction medicine consultant service at the Royal Alexandra Hospital. Our next panelist is Chris Mccree. He has a BSc specialization in genetics, a BSc in pharmacy, registered pharmacist, and has his APA. He's a clinical pharmacist who works with patients from all walks of life as an integral part of the interdisciplinary-based acute mental health team at the Grey Nuns Community Hospital here in Edmonton. As a clinician, Chris believes that the treatment of mental health needs to be approached from a patient-first perspective of education and autonomy. Complementary to this, utilizing the talents and training of a wide multitude of medical professionals will result in the most positive of outcomes. Over the last 19 years, Chris has garnered the respect of his patients, colleagues, and students by providing exceptional care in the pharmacological treatment of the full range of mood and psychoses-related disorders, including treatment-resistant depression. Stephanie Geizel is a graduate of the BSc Pharm program in 2009 from the University of Alberta and the PharmD program in 2020. She has worked as a pharmacy manager since graduation, and in 2020 was appointed as a Vice President of Pharmacy Operations for Western Canada with SRX Health. Stephanie is passionate about practicing to the full pharmacist scope and creating novel community pharmacy programs that fills gaps in our healthcare system. And last but not least, Ron Pohar, who completed a Bachelor of Science in Pharmacy degree at the University of Alberta in 1995 and graduated with distinction. He He has 25 years of experience as a clinical pharmacist in Edmonton's inner city and specializes in the areas of smoking cessation, mental health, and geriatrics, and provides on-site clinical pharmacy services, including specialized smoking cessation, addictions, and mental health services to patients at a number of facilities. Over the years, Ron has developed and delivered many print and live continuing education programs for pharmacists and other healthcare providers on a number of mental health topics, including depression, schizophrenia, and specific drug topics such as atypical antipsychotics and clozapine. I'd love to invite all the panelists to turn on their cameras and give us a wave. Phenomenal amount of experience on our panel today. Welcome. So let's start the night off with Stephanie discussing her case study and sharing her learnings and experience with us. Welcome, Stephanie.
Thanks, Ravina. So my patient case is kind of a case / some mental health communication pearls that you can really use in a community setting with patients. So my patient case is a 30-year-old female that was originally referred to me for diabetes education after being newly diagnosed with type 2 diabetes. Her endocrinologist had sent me her consultation note and a detailed medication or medical history that showed she also had PCOS, she had a BMI of 38.8, and was being treated for depression with citalopram. My process with patients is to first address their concerns prior to my or the referring physician's agenda with the patient. I feel this method shows patients that I am interested in what is important to them and to help build trust with them. To show patients that I care about what they're saying, I always use active listening techniques and open-ended questions to create a professional relationship. At our first appointment, this patient was super concerned about how her weight was contributing to the development of diabetes. We discussed the mechanisms of PCOS and genetics on type 2 diabetes. We also completed the standard diabetes education principles. And at the end of this session, she said that she felt very comfortable with me and that she felt she could be honest about her concerns. It's important to actively listen, to have open body language, and to maintain eye contact when you're talking with your patients. After 2 to 3 sessions, her chief concern slowly evolved from diabetes to weight management and mental health. I asked her if she felt that anything in particular had driven her weight gain in the past, and she became quite emotional. She said she had always used food as a means for comfort. She disclosed that she had struggled with depression due to a strained relationship with her parents, as she is a member of the LGBTQ community, and this goes against her religious upbringing. She said she has never been able to discuss these issues with anyone in healthcare in the past, as she felt no one would listen. I validated her concerns by saying that it's completely reasonable to feel the way she feels and that I was here to listen and support her. I asked if she had any family or friends she relied on to support her. She disclosed that her girlfriend had experienced a similar situation and that they supported each other. Patient supports are super important, as you can guide the patient back to these supports when they are struggling. And sometimes patients just need a friendly reminder that those supports are always there. Eventually, I linked this patient with a counselor at the Center for Sexuality, as they have individuals who have faced shame and criticism from their families or friends for being a member of the LGBTQ community. I also provided her with a referral to a counselor who has an interest in helping those with obesity, with eating disorders, and disordered eating. I find it important to link patients in with counselors and resources for their unique needs that I may not be able to understand. It's also crucial to remain non-judgmental no matter what a patient is telling you and no matter what your thoughts are on the subject. This patient is usually very well put together in terms of her clothing, her hair, her makeup. When she has presented to me looking disheveled, that's a clue for me that I need to check in. I generally do this by simply asking, "How are you doing? Is everything okay?" I do not see my patients as patients. To me, they're people. We are the same. There is no pharmacist versus patient kind of mentality. I talk to my patients as if they were friends or family. The more comfortable you are in speaking with a patient, the more comfortable they're going to be speaking with you. If you are awkward, it will be an awkward conversation. And unfortunately, you probably won't be able to help the patient in the way that you are wanting to. Not everyone is comfortable talking to patients in this way. Originally, when I started practicing, I definitely wasn't. I was awkward and I felt uncomfortable about conversations around mental health. When I was doing a med review and I saw that somebody was on an SSRI, I would vaguely ask why they were taking it and then quickly move on. I never asked how they were doing. If they were on a blood pressure med, I would ask them at length what their blood pressure readings were like, but I never would ask about mental health. I felt that that was something that you couldn't do. However, a colleague of mine once posed an interesting question to me that elicited a change in my behavior. He asked, what if I was the only person who asked this patient about their mental health? What if no one to this point had taken the time? What if I can make a difference by simply checking in? Everyone on this call went into healthcare as they wanted to help people. We have no issues helping patients with diabetes, with heart disease, with cholesterol issues. So why should mental health really be any different? Why do we assume that if a patient is prescribed an antidepressant, that they have had some in-depth conversation about their mental health issues? To get back to my case, I have been following up with this patient regularly for the last 2 years. She has definitely had her ups and downs, but has always contacted me for support because she knows that I will always listen. I will always support her and I will always just listen. We have used questionnaires such as the GAD-7 and the PHQ-9. I have found this helpful when she's wanted to stop her citalopram in the past, just to really assess if she was in a good place where this could be done. I do find these questionnaires very useful in practice and do use them quite regularly. This patient has also had lows where I felt suicide screening was warranted. I did this by phrasing it such as, I'm concerned with some of the information that you have told me and need to ask you if you've thought about suicide or harming yourself or others. I care about you and I want to know that you're okay. If it's phrased correctly, patients will know that you have their best interests at heart. I have never been concerned about her harming herself, but I will say in the past at other pharmacies I've worked at, this definitely has happened. And that just kind of leads me to my last point, is a lot of patients or a lot of pharmacists don't know how to report a suicidal patient. They don't want to report someone in case they didn't mean what they said. But I'll kind of play devil's advocate here and say, what if you were the only person that they told? I have called 911 in the past on 3 patients, and these patients had all told me very specific plans about how they were going to harm themselves. In all 3 experiences, it was through a follow-up phone call with a patient where they told me their plans in detail. In this situation, I kept the patient on the phone and simultaneously wrote a post-it to my technician and got her to call 911 and to tell them that I had a suicidal patient on the line. I kept the patient talking on the phone until the police arrived. Was it hard? Absolutely. Was it worth it? Completely. 2 out of the 3 patients were completely grateful I did this. Another one was quite angry. However, at the end of the day, I knew that I did no harm and patient harm could have occurred if I had chosen to do nothing. So pharmacists do play a huge role in mental health, no matter where you work. And it's just tiny little things that we can do to really check in with our patients. And that's all.
Thank you, Stephanie. It's beautiful how you create that safe space, free of judgment. I love how you mentioned that a clue could be that a patient that you regularly work with deviates from their normal routine or their normal appearance. Also, thank you for sharing the vulnerability that you carried about being uncomfortable approaching patients initially and working through that. That is inspiring. And thank you for sharing that powerful story about the impact you made and saved those lives by just taking that leap of faith and doing what you thought was best at that time based on your assessment. Thank you for sharing your story.
Thank you.
I'd like to welcome Ron next to share his case study and his experience.
Thanks, Ravina, and thanks, Stephanie. That was a great case. So my case is focused on a site in the inner city that I go to twice a week. It's a site that I round at with a family doctor 1 day a week, and with a psychiatrist another day a week, and we work in a multidisciplinary team. So the case that I was going to present is on a 30-year-old male who has a long-standing history of schizophrenia for several years. It's a complicated case in the sense that, given the client's limited insight into his illness, he has a guardian, and a guardian is a family member. So the reason I thought this was an important case to sort of highlight is really about where and when to seek family involvement, some of the barriers around that, some of the challenges that we are presented with as pharmacists when we have to share information, not necessarily with the patient themselves, but guardians and family members. So again, this gentleman has a long-standing history of schizophrenia. He had adherence challenges that were ongoing. Substance use off and on, some crystal meth use, some alcohol use. Like most people with schizophrenia, he's a current smoker and smoked typically about 3/4 to a pack a day, but again, on limited income. So oftentimes it would result in a lot of cigarette butt picking and that sort of thing as finances became challenging later in the month. This gentleman, we had tried him on several antipsychotics with limited effectiveness. He had been on risperidone, he had been on quetiapine, he had been on olanzapine. So he had been on 3 atypical antipsychotics. We considered long-acting injectables in this individual. It was very clear to us that it would probably become a challenge with that. The nurses were worried, as there was some aggressiveness in the past with this gentleman. So as we sort of work through some of the challenges, the different medications that we tried, we realized that we needed to get some family support with this individual. So again, limited insight, he was hearing voices regularly, he was increasingly paranoid, and it started to become difficult because his paranoia was around some of the other co-residents. So he started accusing them of stealing his clothes, he was accusing them of coming into his room. He started to accuse staff that they were taking stuff from his room. So it was getting to the point where, with this individual, there was talk about having to move him out of the facility because the staff was having trouble managing him. And the site that I go to is, in all intents and purposes, sort of the site of last resort. And from a stable supportive living setting, the next sort of setting for this gentleman would be sort of shelters, which probably wouldn't serve him very well in terms of his needs. So what we ended up doing with this gentleman, after tinkering with his medications for probably 6 months to 9 months, trying different agents, trying to enhance adherence, trying to work with the individual, is we ended up initiating him on clozapine for treatment refractory schizophrenia. based off of his use of antipsychotics, and based off the guidelines, he would certainly be a candidate for clozapine. So that's what we ended up doing. The individual also has diabetes and dyslipidemia, so he was on metformin and Januvia, and also on Crestor for his lipids. The other reason we looked at clozapine with this individual is he was polydipsic, and so what also led to some of the challenges that we would experience with this gentleman was that he would obviously overhydrate himself, become hyponatremic, he'd become confused. When he became confused, things sort of just went further downhill. So clozapine is a great agent in terms of antipsychotics for polydipsia. So that was another reason why we decided to go with that agent in this individual. So his sister is the enacted legal guardian. And so his sister had very limited insight, was very much in denial, was very mistrusting of the healthcare system, and was very mistrusting of the healthcare team in how her brother had been managed just over the years through the healthcare system, and really didn't have a good understanding of schizophrenia, and attributed really everything that was going on with this individual to the underlying substance use, and also just to the fact that he hadn't had a real stable environment over the years. So really didn't know what the need to medicate a lot of this stuff, a lot of the symptoms, what the need for the medications really was. And so I think what this case really highlighted to me was that we needed to convince the family, in this case the sister, given the fact that she's the enacted legal guardian, around the benefits of treatment, what the plan was for monitoring, particularly when we started to talk about the need for blood work weekly for 6 months in order to monitor neutropenia for clozapine. She was very reluctant around this, was very reluctant about that intervention. So we sort of had to do a lot of education around, these sort of residual symptoms that persisted, and what the next step was, which was the facility wouldn't be able to house this individual anymore if we, couldn't sort of get this under control. So in a nutshell, the individual was put on clozapine. He's done fairly well, still has residual symptoms, still has very limited insight. Paranoia is very much resolved. Socially engaging with some of the other residents, which really had never happened since the individual moved in. Was compliant with blood tests, had some hypersalivation, was easily managed with glycopyrrolate for the most part. And so I think for my case, the takeaways really for me was that when patients have severe and persistent mental illness, it may not just be about the patient, particularly if they have limited insight, have poor decision making, have difficulty in terms of adherence challenges, relapse, those types of things that we may need to get family buy-in and support. And that there's a lot of myths and misinformation around medications used to treat mental illness like schizophrenia and bipolar disorder. And it's important to provide accurate information, and I think really highlight benefits over risks. I think one of the challenges is I think it's important for pharmacists, we got to give perspective, obviously, for adverse effects and those types of things. But I really think 80% of the discussion should be around the benefits and how this is going to improve the quality of life of individuals with underlying mental illness, and then talk about the adverse effects, but really give perspective around how most of the adverse effects typically are transient, self-limiting, and they can be managed effectively. So anyways, that was my case that I wanted to bring forward. Thank you.
Thank you so much, Ron, for sharing that. You articulated and painted a picture of the struggles our patients experience, and being a clinician and watching that spiral downwards. I was recalling a patient that I had in Collingwood with a similar history. So yeah, it definitely stays with you for sure. And like you said, what resonated with me is that the many facets that feed into the care of that patient, where the sister was a key player in terms of her brother getting the help that she needed. So that really resonated with me. Thank you so much for sharing your story and your experience. I'm going to hand it over to Nisreen now to continue with tonight's event.
Thank you, Ravina. And thank you, Ron and Stephanie, for sharing these great cases. It seems like you guys definitely, well, given me perspective at least on how pharmacists are making such a huge impact. So now I'll introduce Chris to discuss his perspective and his approach. Thank you, Chris.
Thanks, Nisreen. Thanks also, Stephanie and Ron. Those are spectacular cases. And in my discussion, hopefully I'm going to build on a few of the themes that you've already established. So I don't have a particular case for you tonight. Kind of when I was asked and I approached this situation, I'm sitting in a little bit of a different boat than some of the other panelists and a lot of the community pharmacists for sure. So in my workplace, I'm sitting in a acute mental health unit, large unit at the Grey Nuns Hospital. So my patients, they're admitted inpatients. So they've already been through the ER, they've talked to their psychiatrist, they've probably seen a resident or two, they've interacted with nursing. Depending on how they were admitted, they might have been in the ICU for a few days if it was an overdose or something, or just a general medicine unit as well. So I've got the luxury, I guess, that most of the attendees don't have, that when I get to a patient and approach a patient, I've got a confirmed diagnosis. I've got a complete history, and I spend a lot of time with the history because I really need to know where that patient came from and how they got to me, I guess, to my unit, to my team. So I've got this history, I've got the chart, a full chart, and I've got all the lab work from their acute workup from the ER. So really, my job is in a stabilization type unit. So we get patients that are really not doing well. Our mandate is to get them stable as quick as possible, and then get them back into the community. So back to you guys essentially as their primary healthcare team. So I've got just a ton of respect for all the pharmacists out there working the front lines. I did so myself for a number of years. It's been a while, but I think back to those cases and where mental health patients approached me and I really didn't know how to manage it, how to handle it, what questions to ask. So kudos to all you guys out there. So I guess my job is to form a fast, trusting relationship with this patient. Like I say, I'm not the first healthcare professional that they see, but I bring something a little bit different to the table than some of the other guys might bring, right? So it's an approach where you do need to build that trust quickly, and that trust is built. As Stephanie said, you've got to be confident. You've got to be confident in your abilities. And if you're awkward, it's going to be awkward. So ask the question. The patients that are on my unit are generally very, very willing to talk about their situation, their drug history, medical trials, what's worked, what hasn't, that sort of thing. So I'm going to kind of take it now and focus on the themes that kind of got them to the hospital, and sort of what we might do a little bit better to prevent it from getting to that point. So to build on Stephanie and Ron's comments. Right now, in the age of COVID, we definitely are seeing a greater proportion, I would say, of what you might call the adjustment disorders, which is kind of a newfangled way, DSM-5 way to say a nervous breakdown is essentially what an adjustment disorder might be. So right now, the isolation from COVID isolation is really, really detrimental to a lot of people that have previous mental health conditions. And it's developed, not developed, but helped to lead to a lot of new presentations of mood disorders, especially. So with the isolation, the other big factors that we need to consider, I guess, the Alberta economy. Like going into COVID, it's not like we're in a happy place where oil was $110 per barrel and everybody was working and things were a little bit nicer. So coming out of this financial crisis into COVID, it's an accumulation of stressors. Put on top of that, marital stuff, family stuff, school stuff, substance abuse, and it's this cumulative type effect. So when I approach patients, there's not too much I can do about those things. So I'm the drug guy. So we can talk about your medications. We need to set boundaries and expectations on those medications, and we need to address some of the other things, of course. But the expectations is really a big thing, because a lot of patients are really looking for that magic bullet, I guess. It's like, just get me the one that's going to work. And it's like, well, the medication can do so much, but we really need to address these other things in your life. So another common theme that tends to put patients onto my unit is the classic medication compliance conundrum. And that's somewhere where pharmacists can really help out a lot. For the most part, patients will stop their meds because of potential adverse effects. And the other big one is that they just think that they're not effective. I'm like, I've been taking this and it's not effective. And honestly, a lot of times when they stop that medication and they decline, that's the point where it's just like, well, the medication definitely was doing something. So speaking to patients on that is crucial. It's not that the medication is going to take you from 8 to 10, but maybe it's holding you at 8. Instead, you'd be at 4. So family members or spouses essential to talk to as well, because a lot of times the patient doesn't even recognize that they might be starting to decline. And there's a lot of different presentations, right? It's not just I'm sad. It's things like sleep, it's anxiety, it's irritability, it's catatonia, it's a lack of memory, a lack of concentration. Those are all kind of things that you might be able to pick up on and take that discussion to like, okay, we're talking about sleep, but maybe this is a bigger picture that we need to look at. back to Stephanie and her suicidality conversations. I couldn't have said it any better. She did a really good job in presenting those, that if a patient is at a point where they're talking to you about it, it's not an impulsive, I just came up with this off the top of my head. If there's a plan in place, you really do need to be worried and you really do need to act. And kind of just to sum everything up, I guess I'm most haunted by the patients that I've never seen. The impulsive suicides that is running rampant in our society right now. Young, productive men and women are very efficiently and effectively harming themselves or killing themselves, and they don't get the chance to try some new pharmacologic therapies. They don't get a chance maybe to try ECT or ketamine or some of the newer therapies. So, you know, back to the common theme, ask the question, start the conversation. Hey, how's it going? Sometimes can open up a big door and potentially save somebody's life. That's it.
Thanks. All right. Thanks, Chris. And thanks for sharing these fantastic points and how you were able to approach these patients that were admitted with an acute mental health crisis. And I find it amazing how you're able to put the patients at ease and sort of start that conversation with them. And I think that's the first thing that we need to do. And as a pharmacist who practices in the community, I can certainly translate this and, you know, help use these like points that you've discussed to help vulnerable patients. And I think it's very important as well, like you mentioned, to highlight those expectations with patients when it comes to pharmacotherapy, and you know, being clear and trying to involve as many people in their care. So thank you, Chris. So I will now introduce Essie to speak about her experience.
Hi, everyone. It's been great to hear everyone's cases and stories and their strategies. Like Chris, I kind of took a little bit of a different approach and wanted to speak to some of the systemic implications that I think have impacted my patients' mental health during the pandemic. So during the pandemic, our hospital was designated as one of the key sites for completion of public health mandated isolation for quote unquote recalcitrant patients. So primarily mandated isolation can come about in two general scenarios. One is for individuals who are unable to isolate in the community, and two, for individuals who are unwilling to isolate in the community. However, we were also presented with scenarios where individuals would come to the hospital with a different presenting concern, sometimes something very acute, sometimes something they'd been putting off because there was a lot of messaging to avoid the hospitals, to leave the emergency rooms empty, and then were incidentally found to be COVID-19 positive or a close contact, and then required admission for the completion of their isolation. So I'm the practicing pharmacist on the ARCH team, and our mission is to support individuals who are experiencing substance use disorder and or social inequity while they're in the acute care system. For many patients, using substances is a strategy for coping with mental health and emotional regulation. And at baseline, we know that the acute care system is a risk environment for people who use substances. Longstanding policy encourages people and forces people to use in isolation, not to share their full medical history or substance history with their healthcare providers, which isolates them and creates very dangerous situations. And so long before COVID, our team has made efforts to improve our patients' experiences in the acute care system using a multifactorial approach. So access to medication management, such as opioid agonist treatment, access to harm reduction interventions that range broadly from managed alcohol to an inpatient supervised consumption service, access to counselors, support in meeting their social determinants of health, connecting patients to peer support workers, people who have lived experience, and ultimately connecting patients to community resources and providers so that our interventions are not just static in the acute care environment, but that we connect them to people who can help them reach these goals that are sometimes more longstanding. But even during this pandemic, it has really pushed the limits of our creativity and efforts to implement patient-centered approaches in really like a completely disrupted environment for patients, and even really a completely disrupted environment for us because everything got turned on its head. And so it very quickly became evident that mandated isolation could be extremely triggering for our patients. So in many circumstances, it unpacked a significant amount of trauma related to institutionalization. Social distancing and PPE in many ways also triggered the internalized stigma that a lot of patients already feel from healthcare providers. There's a tool that I refer to often, and it's called the stigma to sickness slope. And it does a really powerful job of showing how stigma perpetuates marginalization, which perpetuates sickness. And I think that a lot of things that came about in this pandemic really accelerated that slope from stigma to sickness. Patients struggled with rapidly changing expectations and rules in the hospital. And it also highlighted the lack of environmental enrichment that's available in the hospital. So we really dramatically disrupted people's ability to connect with their communities and their families. We compromised their ability to be entertained and have connection by forcing isolation. So not only did we significantly impact our patients' mental health, but we undoubtedly compromised their trust of the healthcare system. And I don't think we could have ultimately predicted the implications of what would happen with this mandated isolation and having it happen in the acute care setting. And so I really tried to think about, my practice is very specific and niche, as Chris had kind of alluded to in his description too, but I really think there's overarching pieces that we can all take away and learn from this experience. And what really continues to be highlighted to me is the fundamental importance of relationship-based care. And so in school, we learn a lot about patient-centered care, which is critical, but this term relationship-based care has really stuck with me my entire professional career. And so pharmacists in the community have a really unique opportunity to build strong, long-lasting relationships with their patients and have, bonding over time. And so when I transitioned from community practice to acute care practice, I really feared that this would be lost. But I did learn that this is also a learned skill, and it's not solely a product of your practice environment. And so you can learn ways to kind of implement it in small ways and maybe expedited ways to build that trust with your patient. And so time and time again, I'm just reminded that small actions really do have large impact. And so there's things we can do every day in all of our interactions to have this impact. So creating a safe space with the language that you use, the tone that you use, demonstrate a willingness to listen and learn, especially when people are sharing with you their struggles and their feelings. Explaining the purpose of your questions and being authentic if you don't understand something and that's why you're asking. Acknowledging that patients are experts in their needs. And so we should often ask them what they need because they often know the answer. Allowing space for patients to identify these needs and not just solely focusing on the checklist and intention of your intervention. Being aware of your body language. I think this one is even more important now in the context of COVID. So often I'll be like, I'm smiling under my mask. I know you can't tell, but as a way of, showing that I'm interacting and I'm bonding with them, or I'm acknowledging if they've made a joke, using your nonverbals as a way to convey acceptance, not promoting otherness. Appropriate self-disclosure and humor can also be a really powerful way of humanizing interactions that have really become more distant with forced 6 feet and PPE and masks. Practicing always in a trauma-informed way, and always communicating sensitivity even if patients aren't ready to share yet. And it's kind of the accumulation of these small things that pave the way for our patients to really feel seen and heard. And I'm just reminded always of how important these things are to really support our patients to open up and seek support and ultimately begin healing when they're ready.
All right, thanks, Essie. Yeah, so yeah, thanks again for discussing how you provided this care to patients. And I think, like many people can relate, COVID has definitely had a significant impact on many individuals. And, thanks for sort of explaining how, you had a strategy to support these patients and create that safe space for them. So that was amazing. And also, like you mentioned, like small actions that have a huge impact, and I think especially with COVID, a little bit of humor, I think goes a long way. So yeah, thanks so much, Essie. So now, with all the speakers, thank you all for your sharing your experience and your cases. We are just going to open it up for some questions. All right. I'll just be a minute here. So we'll start off a question. This is open to any of the speakers, so whoever feels comfortable discussing this question. So question from the audience is, could you discuss remission in depression? At what point is someone stable enough to try discontinuing their medication? And what are some considerations you look at? Okay. So is there any speakers?
For me, like what I had mentioned in the case was going through the PHQ-9 and the GAD-7 with the patients. I do find that really does give you kind of a real-time estimation of what's actually going on with them. I find a lot of people play with Dr. Google and really think that they should come off of their meds right away, but just kind of having that very objective number from those questionnaires, I find really does help guide the recommendations.
If I can add to that, I think it's important also for us to give patients very realistic expectations. And so if it's an initial onset depression, I think from the outset, we need to do a really good job of setting up what the plan looks like. And the plan really should be a minimum treatment time of 9 months to a year. Off the initial, if it's an initial instance of depression. And then I think for those that have long-standing depression, those that have suicidality, those that we consider potentially treatment refractory, again, I think it's important for the team to make sure we give them realistic expectations about what the risk of relapse is for discontinuation, and let them weigh risk versus benefit over the long term and what that looks like.
Thank you very much for answering that question. And panelists, you're welcome to share your video while we have this discussion. So thank you. We are getting a lot of thank yous coming in for the panelists. Thank you for sharing your story. We have some questions coming in on what are some resources or counseling services that you curated or are suggesting, especially for those who may be financially strained and also those who work a 9-to-5 job and may not be able to access a counselor during working hours.
We primarily work with counselors who are quite focused in addictions, but there is a service called Access 24/7, which is intended to be kind of a central hub for all access to mental health supports. And so there are, and like, please anyone feel free to step in, but there are referral pathways through there to counselors and other more specific services in the community and to psychiatry. It is intended to be available 24/7, so it kind of helps those people who have a 9-to-5 commitment.
In Calgary, there's also the Calgary Counseling Center that does have some more affordable psychologists. as well as there are many psychologists, like the ones that we refer to for weight management. He does evenings and weekends, and it's just really about networking and finding those resources for your patients. And at the end of this, I'm happy to share my email address with anyone if they do have questions for kind of Calgary-based people.
I think one thing that's been really apparent to me after practicing for a couple of years is there's not a lot of culturally specific counseling supports, and also counseling that's in other languages. And so that's been a huge barrier for us. And you see patients that really struggle and would benefit from that, and there's just nowhere for them to access. So that would be definitely something I would hope to see become more available or accessible. I don't know if anyone else has any resources they want to share with us that I'm just not aware of, but.
All right. Thank you. So we just have another question here. It's saying that Stephanie mentioned referring patients to a counselor or mental health organization. Do you have a recommendation on potential places or people that we can share with our patients?
Yeah, I can pop some names into the chat, as well as if anyone wants to email me directly after this, I'm happy to share that too.
Okay. Thank
Fantastic.
you.
And we'll circulate some of those resources after we've talked to our panelists. Another question coming in, how do you identify patients who may not be openly saying that they need help or have a history of a mental health condition? What else do you look for to identify these patients and form that bridge?
In community, I see people obviously at all times of the day and at all times in their journey. So just kind of looking at mannerisms. So are they really tense when they're generally a more relaxed person? Are they tired? Has their tone, the rate that they're speaking or the rhythm of their speech changed? Are they making eye contact? Do they seem unusually awkward? Are they speaking logically? Is what they're trying to explain to you makes sense? Those are kind of a few other things, along with more the physical appearance, like the hygiene standpoint. If you have somebody who is like a three-piece suit kind of guy and they come in wearing sweatpants and a hoodie and look like they haven't shaved in a week, that should trigger you to ask what's going on.
I think for me too, like patterns of substance use. So one of our counselors described it once as like substance use is the fin, it's not the teeth. And so substance use can kind of be the indicator of something bigger, more serious that they're trying to process. And so having, understanding of someone's history or baseline and how that maybe has changed can be a clue that they're trying to work through something.
And I think Essie raised a really great point too about substance use. Are you able to expand kind of on how you would ask a patient about substance use that is not in an offensive way?
Yeah, that's a great question. And like you kind of shared when you first started, it is awkward and you kind of have to find your footing and understand how to ask in a way that's appropriate and safe. And I always kind of come back to this story where in my first year pharmacy lab, you have to counsel about ibuprofen. And I asked this, elderly patient, simulation patient, if they used any substances, and the lab facilitator afterwards was like, you don't need to ask them about substances. And I'm like, but actually you do, because you don't know. And so I think that's one way that has can be kind of a tool that works, is to really approach it equally across all patients and not make assumptions about who maybe uses substances and who doesn't. And I really encourage like transparency with why you're asking. So what is the intended purpose of you asking this information? What is your intention with the information? And I think as pharmacists, you can explain that sometimes this can interact with prescribed therapies and other treatments that we're trying to explore. And so it's important for us to know all the picture, the entire picture, and I ask about it like a drug. What's the route? What's the dose? How often do you take it? What benefit do you derive? What are the side effects? I think sometimes we overestimate that patients only have negative impacts, that they don't derive benefit, but sometimes patients will be very transparent with you about what the benefit is that they derive from it, and that can help you understand too why they're using it and the pattern that they're using it in. Thanks for the question.
All right, thanks. We have one more question here. So how do you guys maintain boundaries with your patients?
Don't give them your cell phone. I learned that.
Other than not giving your cell phone number, is there another other sort of strategies that you guys use to maintain those boundaries?
I think a lot of it comes from just, I guess, like having insight into what your own personal boundaries are, what you feel is appropriate to share and what you don't. And that sometimes changes patient to patient and scenario to scenario. I think sometimes when you have these like really long-standing relationships with patients, it's almost like disingenuous if you never share anything about yourself, but you have like an extreme amount of personal and sensitive information about this other person. So, you know, I think everyone has to decide what is safe and appropriate for them to share. And so maybe that's how you kind of gauge the boundary.
And just building on that, I mean, we're as clinicians going through COVID as well. We have our family life, kids are getting homeschooled, but we're also providing care to our patients who may be struggling as well. How do you avoid or manage burnout? How do you take care of yourself during this time?
I think you really need to recognize what your triggers are and when you're starting to see things going kind of downhill. I know I personally had some burnout definitely earlier this year, and my symptoms that I noticed was I was forgetting things like crazy. I was tired when I really should not have been tired, and just this feeling of being overwhelmed all of the time, and just realizing that, having the insight, and then taking some time for yourself, because if you don't take time for yourself, you're not going to be able to take care of your patients.
Yeah, and I think it's really, I think it's helpful for people when they share, and it kind of takes the weight off a little bit. And so I know for some patients it's meant a lot when we're like, this is a lot for us too. And so it makes them feel a little bit less alone, even though our experiences are so different. It's that they're not alone in it.
Thank you. There was also another question coming in, and maybe Chris, you can comment with the diversity in patients you see. Any tips for parents or for us in terms of talking to a younger population, adolescent population, and discussing their mental health?
So that's really a tough one. You know, with a younger population, especially if they don't want their parents involved, it really kind of is in that gray zone between, you know, confidentiality versus what is best for the patient. So no, like, I don't know, I guess I can say that a lot of people, a lot of the population will look at mental health and mental health patients. And there's an assumption sometimes that that person is potentially unintelligent. And it's kind of a dangerous and completely false pretense, right? Because even at the height of psychosis, I've talked to some patients that are extraordinarily intelligent. So just like an adult with an adolescent, have the conversation, ask about things, ask how things are going, take it from there. I guess a few things that I'll add, just in relation to kind of the first question of when to stop an antidepressant, I want to direct everybody towards the CANMAT guidelines. In general, it's sort of assumed that it's like, well, mental health really doesn't have the guidelines set that cardiology has, for example. And it's true, we don't have the evidence or the studies, but CANMAT, it stands for the Canadian Network Mood and Anxiety Treatments, is an expert committee. They come out with guideline updates every few years, and it does tell you, like, what does the evidence show, plus what are these expert committee members seeing and doing in practice. So CanMat's a great resource of what to start, when to switch, strategies, what to do in special populations, and that sort of thing. And the last point I'll kind of make on this is, if you are concerned about a patient, truly concerned, don't send them home, don't send them to their physician, send them to the hospital. Because when they do hit the ER, it just starts a whole process. The Alberta Mental Health Act kicks in, right? So if you've got a patient that really is really not doing well, but wants to leave, there is a certification process that it's like, hey, no, we need to hold you here and we really need to assess what's going on. So the Alberta Mental Health Act really kicks in to protect the patient and to protect the people trying to take care of the patient. So in the ER, they will see a mental health specialist. They will be fully worked up. They will be fully assessed. And then maybe they'll get to go home, or maybe it's just like, you know what, you really should come in for a period of time. We need to get you better. So if you've ever got that spidey sense tingling, that feeling in your gut, I get a lot of questions from people that it's like, hey, do you know a psychiatrist? I'm worried about somebody. And really calling up a psychiatrist, especially right now, you just can't get in, right? Like there's no resources there, but they always will be fully worked up and assessed in the ER, and then decisions will be made from there. So that's my advice. If you really don't know what to do, the hospital is kind of a guaranteed way to go for assessment.
Thank you so much, Chris. As you keep talking, more and more questions are just flooding in, and that speaks to the appetite for this topic and learning in this area. We are going to be wrapping up here shortly, but maybe give you just 30 seconds or so to think about what parting thoughts can you provide us if we're feeling that inertia and we don't know where to begin in terms of forming that bridge. What is one thing we can say to ourselves or do to change our practice? I know many of you have already discussed this. So I'll start with anybody on the panel who'd like to share that to conclude.
I think one message that's kind of been impactful for me as I've gone on in my training, and I can't remember who I heard say this, but when you're in a situation that feels challenging and you don't know how to respond, and you're feeling kind of overwhelmed by the patient's presentation, instead of kind of having thoughts around like what's wrong with you and feeling frustrated, try to reframe it into the perspective of like what happened to you and how can I help you.
Thank you. Ron, go ahead.
For me, I mean, my practice is inner city, so I think, it's really important to know what resources and what agencies are available to help support patients. It's really a community that has a lot of resources and support, and there's a lot of overlapping agencies that provide that support. So I would say, get to know what resources and supports are available and connect with the interdisciplinary teams. A lot of patients are connected to social workers or connected to mental health therapists. There's a lot of resources that are available. You need to know what patients have in terms of supports.
Thank you, Ron. Stephanie.
I think too, just kind of not beating around the bush with mental health. If you genuinely are concerned that somebody is going to commit suicide or has expressed some thoughts to you, ask them. Don't ask in a very convoluted way what's going on. blatantly ask in a caring way, have you had these thoughts? Is there anything that I can do to support you? And just be there for your patients.
Thank you, Stephanie. And Chris, I don't know if you have any additions to add. I know you shared so much of your wisdom in the last question, but please go ahead.
Probably about the last thing I'll add is, for me, it's about communication, and it's sort of finding common ground. So that's how I teach all my students. I'm like, listen, we do again have the luxury of being impatient. So that patient's going to be there the next day. So sometimes, you know, if I approach a patient for the first time, if they're really in bad shape, if they're psychotic, if their mood is really low, you don't necessarily need to go in with a list of questions and expect to get those answered. A lot of times it's just finding that common ground, you know, seeing a young kid with an Oilers cap, comment on it, be like, oh man, I'm a hockey fan too. And it's just like, my name's Chris, I'm the pharmacist. I'm around here. I'm going to come and chat with you tomorrow. And it gives them 24 hours to just kind of be like, oh, you know, that guy was, you know, he talked about my hat. That was cool. And it's just a simple thing you can do. And you find that common ground. And the next day, you know, a lot of times they're like, oh, hey, pharmacist guy, I have some questions for you. So, you know, in some situations and with the community guys, you do have these relationships with patients. You do see them a lot. So find that common ground and build that relationship, and you'd be amazed, you know, what they'll disclose to you that they might not be telling anybody else.
Thank you very much. Yeah, it's about those simple connections. Thank you once again to all our panelists. We're still getting flooded with questions, but we'll have to conclude here tonight. There is a lot of requests for resources, especially in the areas of screening for suicide risk and smoking cessation. So we'll definitely be hopefully curating that to send out. Thank you for your time. We're so grateful for you sharing your experience. And I will hand it over to Nasreen to wrap up this evening.
Right. Thank you again to all the speakers for leaving us with those fantastic final thoughts. Thank you, Chris, Essie, Stephanie, and Ron for that thought-provoking discussion. And thank you, Dr. Singera, for helping moderate the event as well. And I think we have definitely started the conversation about mental health, and hopefully we can continue this conversation in other webinars coming up. And thank you all to our audience members for joining us today. And thank you to our co-hosts, the Alberta Pharmacists Association and the Faculty of Pharmacy and Pharmaceutical Sciences. So we encourage you to stay connected to the University of Alberta, PAA, RXA, and the faculty through our many volunteer and professional development opportunities. You can follow all of us on social media, just to stay in the loop. And so with all that, this concludes our webinar. And again, thank you for joining us, and I hope you enjoy the rest of your evening.